Shall I share my screen again then?
Yeah.
I mean, if we could make the second hour quite informal and people shout out if interrupt me if you want to, that would be great. Are you happy with that, Chris?
Absolutely.
Is that better?
Indeed, that's perfect.
Okay, great. So really in this part, it was looking more at the practical side of things, and so a little bit more about fixation and what you're trying to achieve, because as we've discussed, there are whole generations who have not really seen acrylic bone cement used and are frightened of its handling characteristics, understandably, because you've got a certain period of time for it to go off. But as you get the team together, it's quite easy to rehearse what you need to do. And this is to make the point again that the primary point about cementing technique is you're trying to force the acrylic bone cement into the endosteal surface of the femur. So it's important not to remove the trabecular bone, because you have to get the cement into the trabecular bone. Cement doesn't work in the revision scenario where you just got cortex, because it can't get mechanical fixation. That's why you need to use allograft bone and impaction grafting. So it's quite different, and you can often tell if a resident comes and they've been to a place that uses uncemented hips, that they get this bloody great piece of metal down, and then they will waggle it to see how well fits down the broaches. With this technique, you don't do that, of course, because you're trying to leave the trabecular bone down there. You broach, but it's not a harsh broach, and you leave the bone down there. And then what you're trying to do, once you've forced the bone cement into the bone, is protect that interface from the effects of bleeding. And this was something else, again, that Robin noticed, is that when he was doing his original cementing, he would see blood between the cement and the bone. And he thought, well, that can't be very good for him. So he did this experiment where he put a suction catheter down into the femoral canal, blocked up the top end with a mix of cement, put saline in, then he used it as a manometer. And can you see here, there's the meniscus of the blood column. Unfortunately, it's against the edge of the wound. But then he would measure that distance and work out the back bleeding pressure. Now, of course, we never see back bleeding pressure like this now, because we use spinal anesthetic and the blood pressure is a bit lower, and we wash the bone so well that we frighten it to death and it doesn't bleed when we're cementing. But this was back in the 1970s, and it really made him realize that what you're trying to do is not only force the cement in, but keep it there. And then he looked at he measured it. There was a clinical impression of the bleeding. He measured it, and then he looked at the effect. So there were some that was very heavy, and the highest bleeding pressure he ever measured was 36 centimeters of saline. But then he looked at the X-ray appearances, and really they had better appearances if there was a low bleeding pressure. So you need to keep the pressure low and keep the pressure on the cement throughout the entire period that you're applying the cement. And another experiment that Clive did was they had a column they had some cement, they had a Perspex tube into which 81 millimeter holes were placed. And then they allowed the cement, that they put it within a way that the cement could get through the holes and displace the cement. And what happens if you didn't apply pressure was the blood went into the cement, and if you applied pressure, it flowed the other way. So you need to maintain pressure high enough to prevent back bleeding. So what about the acetabulum? This is a bigger wound than we would normally use, but just to show you what you're trying to achieve, you want to get down to trabecular bone if you can, or if you don't, get to subchondral bone and make lots of drill holes. So we would go down to the true medial wall, where that piece of, the ligamentum teres is, and then expand sequentially up to take the cortex around the cartilage around the outside, and some of the cortex if you can. And then you need to get into digitation, so use a high-speed burr. And if you look at the way that cemented sockets fail, it's basically pressure and debris getting around the periphery and finding its way around the interface. Schmaltzried showed this. So what you want to do is get really good interlock right around the periphery. So we use this high-speed burr, a Seabatome or TPS or something, and every hour and a half or so go around the outside, and then use a drill hole into the pubis, one into the ischium, and then an array of drill holes into the wing of the ilium and into the other bones. So you want to get good keyholes and multiple of them, but with this important ones around the outside. So with the large drill, you can drill into that bone. And the sockets I don't like to see is where the very small drill holes, because it would be easy for pressure and debit to get around the outside. And in terms of fixation, you would like to see the sort of cloud of acrylic bone cement go up into the wing of the ilium. And the other way this is done is using the a sucker aspirator in the wing of the ilium. So you can put a suction device on that to take away the lavage fluid as you lavage, because lavage is a very important part of this. And then it actually sucks the cement up into the wing of the ilium. So the lavage is hugely important. So we use, I don't think you should do a hip replacement, certainly not a cemented hip replacement without lavage to clean the bone surface, and it really promotes hemostasis as well. So you can't remove the cortex from the equivalent of zone 3, the medial wall. So for decades now, we've placed some reamings from the acetabulum on that wall, and it works really well, because not only does it get rid of any possibility of a radiolucent line in zone 3, but it stops the cement going under the transverse ligament. And here, this is just showing how the sucker aspirator just aspirates the fluid from the wing of the ilium. And then you peel off your swab. There's the bone graft at the bottom. And we used to use hydrogen peroxide swabs. In fact, we just use saline swabs now, but that also helps stop the bleeding and clean the interface so that the cement can get into it. And then hugely important is to use a pressurizing device. So we have these sorbothane pressurizers. There are 3 different sizes that seal just within the mouth of the acetabulum. And basically your assistant pushes. So with Simplex, you would introduce it by hand by about 3 minutes or from a gun. Don't overfill it, put this pressurize on, and then your assistant will push with their whole body weight for five or 6 minutes. So there's a really extended period of pressurization. And then when the viscosity of the cement is beginning to rise, then you'll put the cup in. And it should be a relatively hard push to get it in. So you'll just dry the surface of the cement as a Charnley style introducer. So the surgeon pushes with all their might medially, your assistant pushes axially, and it's a flanged cup. So you've rehearsed where the flange, you've trimmed and rehearsed where the flange is going to go. And it goes into that position. So it's aligned, the face is aligned with the transverse ligament. It's up and down so that it's 45 degrees. And you see the cement's quite viscous. So you make sure it doesn't move. And then once it's seated, you take off the introducer, push on it, and then clear any acrylic bone cement. But what you're doing with the flange, well, obviously with the pressurizer, and then with the flange, is continuing to pressurize until the cement has actually gone off. And I don't think it takes much longer to do a cemented cup. The only time you really have to wait is now for it to polymerize while your assistant's pushing. So at this point, I just use this time to use a spinal needle and put some local anesthetic around the front of the capsule. So that's how we do the acetabular component. Not sure if there's any questions about the acetabular component, Chris.
We never see the cemented acetabulum in the US, and certainly none of our attendings here are doing it other than for a provisional fixation in a spacer setting. So yeah, to see it and how it can be done, but how it should be done is pretty important, I think, if it were to be considered. Any questions from the residents or fellows or anybody else that's on? Dr. Dunn is also, I think, still on, who's one of our senior emeritus professors, and he was the guy that introduced polymethyl methacrylate here to us at the University of Utah, Salt Lake City, when the FDA, actually before the FDA first allowed it. So, Dr. Dunn, did you ever do any cemented cups? I saw his name on there. I'm not sure if he's able to talk or not.
Yes. All the cups in the early 70s were cemented. We didn't, first 10 years, were all cemented cups. And many of the techniques were being talked about because Robert Ling was very popular, and his theories were not, in the early days, were not that far off from John Charnley's, and I think everybody in the 70s tried to do their technique, and that was the way we started.
Yeah, and they did pretty well. It is technique sensitive, though, I think, isn't it? And of course, the results are much better now. We've got highly cross-linked poly, so I think that's why the results are yes, equivalent now.
I think a lot of the reason that the U.S. went away from good cementing technique and didn't keep trying to improve on it was the thought that the osteolysis that we saw was due to cement, when it was really due to the poor polyethylene that we had. But it gave an opening to cementless implants, which industry really popularized. And be quite honest with you, cementless implants are a heck of a lot easier to use as a surgeon than the good cementing techniques that you use.
Yeah, well, certainly I agree on the socket side. I mean, I think the femurs, well, as we will discuss, is much more difficult to get it right with an uncemented implant, because it's so logical to me that recreating the biomechanics with something where you can change any parameters separately. Yeah, lovely comment. Shall I carry on?
Yeah, I did have a question from one of the residents. He just sent me, wanting to know about what do you do in the setting of periprosthetic joint infection? If it does occur, there's osseointegration in the biologic interface of bone cement. And if you dealt with PJI, and hopefully it's rare, and of course, based on your guys' data, I mean, it would seem to be rare in your institution, but generally speaking, how do you deal with the cement? Whether it's this pressurized up into the pelvis from a cemented cup, or if it's down in the femoral canal. Is it important to get it all out? Is there a biologic interface that protects it? Is it biologically, privileged because of the technique or the implant?
Yeah, it's a good question. Well, it depends really on when it occurs. So if it's an acute infection, then we wouldn't take the cement out straight away. We'd wash it out possibly in the first instance. But then even if we were doing a revision, the thesis goes that the cement bone interface is osseointegrated. And if there is no radiological sign of infection, then there probably is not a cellular layer there. So what we would do is we'd burr up the inside of the cement, check that the cement mantle is complete in the femur, burr it up, which would release some more antibiotics anyway, and then we'd recut the neck. So we'd just take a couple of mils off the top of the neck, and you put a knife down and see if there is an interface or whether it is osseointegrated, because most often you can't get a knife down there. It's completely cement up against host bone. And in that instance, we would leave the cement in the femur. If you've done a really good job in the acetabulum, you could argue that, but often you'd need to take a burr around the periphery, because that's where the soft tissue starts getting in. But the answer is that we've written it up. In the acute situation where the mantle is complete and the x-rays are perfect, we wouldn't remove the femoral cement. We'd err on the side of doing it on the acetabular side. So that's what we would do.
Thank you.
This is making the point with the neck cut, that it really doesn't matter with a collarless implant where you make it. So really, we put a finger breadth above the left trochanter, or halfway between the left trochanter and the articular margin in the inferior part of the head, and then aim to come out laterally. But it doesn't matter. If it's varus or valgus, you might adapt it a little bit, but the bottom line is the neck cut really is not important. And then these are the steps I'll go through, which just to explain what we do. So once you cut the neck off, you want to make a really accurate slot, because you want a good slot that you can pressurize into. And what I routinely do is just take trabecular bone. There's always a piece of cortex, isn't there, at the lateral side of that slot as it goes into the trochanter. And you want to get, if you use a box chisel, it tends to just fracture into the piriformis fossa. If you take just take a trabecular bone and take a nibbler, you can create a really, really accurate slot. And then go down with your taper pin reamer and use that a little bit to go laterally as well. You want to get about a centimeter lateral to the mid-axis of the femur. And I routinely use a burr again at the top end here to create that accurate slot. And if you look down from the end of the table and find that your taper pin reamer is going to the lateral side of the knee, then you're in varus. You need to get further out lateral. And the commonest mistake with this type of stem is that they undersize it and put it in varus because they simply haven't gone out far enough laterally enough. So just check where you are, and it's absolutely imperative to template and to make sure that you know where you're going, and the templating will give you an idea of how far down the stem you should go. And at this point, we would then size the plug. So we've got plugs that are 2 millimeter increments, and you want the first one really that doesn't go down to the level that you want. And the plugs that we use are made of polymethyl methacrylate, so they just bond with the cement mantle. And you want that to be about a centimeter distal to tip of the stem. So if we size the plug now, then the nursing staff can be opening it while we do the rest of the preparation. And then this was the bit I was mentioning about the leg length. So we would template and put the center of rotation where it is in the femoral head. And of course, then you can measure the distance between the shoulder of the implant and the tip of the greater trochanter. So then when you put the implant in, you would put it down to that level that you've measured from the tip of the greater trochanter. So you make this measurement on the X-ray. So make sure you use a scaled image. And here you can see where the shoulder is. You measure it as 15 millimeters. And then when you're broaching the femur, put that on the broach handle. Put 15 millimeters and then mark it on the broach handle. And then when you introduce the phantom to where it's at 15 millimeters, use a needle to make sure you've got the very tip of the trochanter. It gets you within a millimeter or two absolutely every time. So that's a really good tip. So again, you can use the lateral part of the implant as well, just to go laterally, so make sure you're not in varus. And then you're going to introduce it straight down the femur and mark on the handle. It's not marked yet, but it will be. So this usually start one size smaller than the one you're going to use, but of the offset that you're going to use. So it's not a matter of reaming up. And as you notice, there's still a lot of trabecular bone there. So here we just get a pen, mark on there the mark that we know that we've got to get the leg lengths correct. And because it's clothed in the abductors, it's worth using a needle and just checking, just run a needle parallel to that and just check that you're against the tip of the greater trochanter. And then you can do your trial reduction. And when you're going with the implant, we quite often ask questions, well, for people who are used to using collars, how do you know when to stop pushing? Because there's no collar. Well, it's simple, really. You're going to make a mark on the calcar opposite one of those holes, and you're going to know where the shoulder of the implant is. But it's the mark on the holes that really is what you'll make a note of. So you'll see that when you do a trial reduction, you can see that's in the middle of the middle hole. We'll use a diathermy mark and a blue mark there. And then when it gets down to that, so the broach has the cement mantle built into it, that when the real implant gets down to that level, you stop pushing and the leg length's correct. So now we'll do a trial reduction. So
you'll broach up from the size of stability, so you can do a trial with the broach in place. Yes,
I mean occasionally it might subside a little bit, but it's usually the strong trabecular bone left and it's stable enough to do a trial reduction. So we go through a whole series now: extension, abduction, external rotation, flexion, adduction, internal rotation, and look for the kick test, which is really sensitive to changes in offset and leg length. And don't really do the shuck test, because if you know you've done your templating, you know you've got the leg length and the offset correct, and then you look for the stability. And of course, you bring the external rotators up if you cut them, but I'm going to try and convince you all that you don't need to cut them later on in this presentation. So we do the trial reduction. And if you're happy with it, then you can make that mark that I mentioned of that hole. So that's where you'll go to with your stem. Of course, if it's short, then you would aim to leave the stem out a bit. And you can put a metal pin through there and do another trial reduction. If it's long, then you would introduce it more. If you were not happy with offset, well, you've templated. So if for any reason you're not happy with offset, you'd go to different offset size. And then you can fine tune at the end with a plus or minus head. So as I said, noted that the plus or minus heads will change both offset and leg length. So we only use them for fine tuning, and we only have a +4 and a -4 on the shelf. We don't have anything else because there's enough stem sizes and ranges that you would never need more than a fine tune with a plus or -4. And so we only use those for fine tuning effectively. Now, it's not shown here, but we lavage the canal before any instrumentation of it. So we use a lot of lavage to make sure we clean out the marrow contents and the blood. And then we'd introduce the stem. This introducer takes it down to, if that mark is in the same position, it's a centimeter distal to where the stem tip will end up. And it's important that the canal is plugged, so that if you inserted the stem into an unplugged canal, this shows the pressures on both the medial and the lateral side. So the blue is the unplugged canal. You get quite small pressures proximally. The pressures are always higher distally. But if you occlude the proximal end of the femur and use a plug, then you induce very high pressures, both proximally and distally. Of course, you want to get your intrusion before that. But here we can see the lavage being used, and you want this to be absolutely pearly white when you finish lavaging it. I mean, even more pearly white than that, to be honest. And then we'll put down a 2-inch ribbon gauze. As I say, it used to be with peroxide. Gordon Bannister did some work about back bleeding, and he compared ice cold saline with peroxide with just normal saline. The ice cold was the best, but you don't want to slow the polymerization. So if you use a lavage, it does away with all those issues. But you want a really, really dry canal. So we'll leave the suction catheter down there. Then we introduce the cement in retrograde fashion on top of the plug. As soon as the catheter fills, we take it out and then introduce the cement from below upwards. As soon as it's filled, we'll put on this sorbethane proximal femoral seal, and then you push with your whole might, and you'll just see marrow and fat come out of the proximal bone. So with Simplex, you introduce the cement at about 2 minutes. You'll be starting to pressurize by 2.5 to 2 3/4, and then you keep that pressure on for until about 5 or 6 minutes. So you're pressurizing for several minutes, and what you should see is a constant flow of fat and marrow contents out of here, even despite the fact you've really lavaged it. And the other point to make is that the proximal femoral seals that we use in Exeter, they are this half moon shape. And so the bit that goes into the canal is at a very obtuse angle. So it doesn't go very far in. And the reason for that is the other ones, the blue ones and the green ones, that they go in a long way, but you're not really getting cement into the trabeculae right at the top end of the femur. So we're trying to engage the bone right at the top end. So this only just goes into the canal at an obtuse angle, but blocks it off.
What viscosity of Simplex are you talking about going in at 2 minutes? Is that the low viscosity? It seems like at 2 minutes, that's still very runny in our experience.
No, that's normal, but we tend to heat it. So we don't need the working time of Simplex. So we actually there are some, it's about 25 degrees, and that shortens your time.
You also mentioned the distal plug as a centimeter of length between the tip of the centralizer, I believe, to the plug. How important is that? If you're manipulating your height and it gets a little bit too long, or to the contrary, if you sink it a little bit lower, or you didn't seat your plug far enough down, how detrimental is that to this taper slip phenomenon, where we know that we're getting the external pressures and the hoop tensile forces, but distally, what is the level of importance of the distal cement? What if you get it too short? Uh-oh. Is it me?
Not you.
We lost him. It's a long ways for the internet to connect across the pond. Oh no. Let me send her a message real quick. This never happens when you have an in-person visiting professor. We got to get back. I'm just sending him a message real quick. Sorry about this. Residents, ask some questions real quick of Dr. Dunn. Us, what do you guys think about what you've seen so far?
Should we be doing more cemented hips?
Yes.
I think what you're seeing is that this is an extremely technique dependent thing, and not that all surgery isn't, but I don't think you should be doing some hips cemented. I think if you commit to cementing hips, you got to commit to doing it the way they do it, not the way I did it the first 10 years, which was, finger packing. It was definitely first generation cement technique. And I'll be very honest with you. I never gave cement the chance to succeed because I was not willing to go the route that they have gone. And I quickly switched over to totally cementless technique. And I'm right now today, I would be better off doing a totally cementless hip because that's how I can do it and get it done. But that's not saying I don't think my results at 30 years are near as good as theirs are.
Yeah, I think what we're seeing in the US is a shift of that pendulum that I mentioned in the introduction back away from pushing the envelope in cases that we ought to not have been pushing the envelope. We became overly confident and comfortable in cementless in certain cases, whether it's the elderly osteoporotic female, the neck of femur fracture case. These are cases of pathologic bone already, and there really isn't a good reason for us to be putting the patient at risk for periprosthetic fracture when there's a solution that exists that has almost not a zero, but an order of magnitude lower risk of complication. That's the epidemic that I was referring to earlier. We have swung so far to relying on cementless that we create problems in certain cases of patients because that's what we thought we should do. And maybe there's a certain implant design that is more favorable, whether it's Reaming broach or it's fit and fill or it's diaphyseally engaging or it's a sort of modern collared stem to prevent subsidence and rotation that can lead to periprosthetic fracture. There may be other solutions, and maybe it's a one-size-fits-all phenomenon that some surgeons rely on, including some of us and myself in the past. And I think now you'll see us selecting the stems more frequently that match patients' anatomy as opposed to just simply placing one implant that should fit everybody. But I do think that we're seeing, even in the American Joint Registry, as a result, particularly as I mentioned, of the Exeter data, an increased utilization of cemented fixation in total hip arthroplasty, including in these higher risk groups particularly. And I think the data sort of supports that. And we're back. He's back.
Yeah, I'm sorry. I don't know what's happened. It's gone down. I'm on my phone, so I hope the videos will work on my phone connection.
Yeah, so far so good. Thanks for rejoining. We were just talking about once again, sort of the should we be doing more cement in the US and at our institution and in general, and talking a little bit about our evolution in cementless. But yeah, that's working perfectly.
My answer would be yes, of course. But I mean, it'll evolve because I think on that discussion, there are several groups where it's absolutely unequivocal that you should be using cement, and that's the fractured neck of femur group and the elderly group. I mean, you can argue about the young people because I think in terms of survivorship for implant loosening, they're equivalent. But as I was trying to show in that last presentation, I think there are other real benefits for using cement in terms of revisability and ability to recreate biomechanics.
Absolutely.
Anyway, going back to the effect of the seal. So if you use the old Charnley method of finger packing, you get these spikes of pressure. Whereas if you use the pressurizer, during the whole period of application, you get sustained rising pressure, forcing the cement into the endosteal surface. And the peaks here are of the ratchet of the gun as it forces another quantum of cement down into the femur. So is the video running okay, Pete?
Everything's working fine. Yeah.
Is it? But when the stem goes in, we heat the stem in hot saline just so that when it's down, it polymerizes. And if you put a thumb over the calcar area, again, it induces higher pressures down the canal and frightens the back bleeding. So it should be a relatively hard push. And of course, you dial in the amount of version that you want, and then you'll introduce it to that mark on the calcar, get your assistant to help you. And you can see the cement is viscous enough. It doesn't want to move around, but you'll keep a hand on it. The last thing you want is the stem to move within the cement mantle at this point. So you'd introduce it down to where it should be, and then we'll clear the cement. And then Robin and Clive did an experiment where he put on a sorbethane horse collar thing, deformable collar on top of the cement mantle and pushed on it. And the effect of that is to slow the rate of fall of pressure within the canal to protect the interface from back bleeding. So this is the effect of introducing of the thumb on the medial femoral neck during stem insertion. So you can see you induce higher pressures if you put your thumb there. It also helps you position the stem. So if you put it over the calcar area, it makes you put the stem down straight rather than in varus. And also you can direct it slightly to the back of the cut surface of the cut in the neck, because what you don't want to go is front to back. It doesn't matter so much with the extra stem, but you'll see people cementing with other stems, especially if they're matte, with the direct lateral approach. The stem tends to go from front to back and gets an incomplete mantle at the back of the tip, and also anteriorly further up, just the level of the trochanter. So if you put your thumb, you can make sure you're not in varus or valgus, and it also keeps you towards the back of the cut surface of the femoral neck, because of course the femoral neck's more antiverted, so it's more offset anteriorly than the shaft of the femur, if you follow me. So now we'll clear the cement, and then this is the distorted.
Is that you're using the device as you insert it. You pressurize the canal both with the retrograde cementation and the pressurization plug. But then when you implant the implant itself, you weighted to a viscosity and also heated this implant, but to viscosity that the implant is also further pressurizing the cement as you insert it.
Absolutely.
Yeah.
I mean, I think because of the success of the implant, I mean, you know, the survivorship's well into the 90s. Honestly, even if you did a poor job, I'm not advocating for a second you should do a poor job. It's very forgiving, in fact. And so I don't think you could ever prove that you have to go very, very late. You know, Graham and I used to play chicken really with how late we'd go with the stem. You could never prove it made a clinical difference. So wait till the viscosity is rising and then go in with it. And if it is quite a hard push, take your thumb off, and then the cement gets out more easily and it will seep down to where you want it to go. And just a point to make here, you can see it's towards the back of the cut surface of the neck. So there's more cement anteriorly than posteriorly. And again, we've dialed in the amount of antiversion that we want. And then we'd always just check that the mark is at the same level. And this is the effect of the horse collar. So do you remember that first experiment, the 36 centimeters of saline? That's marked on here. So you'd never see back bleeding like that now. Very occasionally you get a canal, as you know, that does tend to bleed copiously no matter what you do. But that's very rare. But importantly, the horse collar doesn't slow the rate of fall, but it kept it above the highest pressure we ever measured. So it does protect the interface. The only slight caveat is that if you push quite hard on it and don't put a finger on the implant, because you're squeezing it, in fact, you can squeeze the implant out a bit and lengthen the legs. Keep a finger on that as well, just to make sure, and just checking that it's not backing out. And then really, I was going to say a little about preservation of soft tissues, Chris, is that all right? And really about the results of hip replacement, because we have very blunt results in hip replacement. We talk about survivorship, but that's really, really blunt endpoint. And we do have one of the two best operations any surgeon does, the other one, of course, being cataracts. But there are 5 or 10% of our patients who are not perfect. And I don't think we're quite as good as we think we are. So we do have registry data in millions of patients, so that's very important. We have PROMS outcomes, but of course there's a ceiling effect on almost all of those instruments. And I think the way we're going to be going in the future is with gait analysis and objective measurements of activity. And of course, with the advance of technology, that's being made much easier. But if you just consider how we walk, it is really quite complicated. If you look at the differential movements, it's quite subtle, and all of these segments are tied together, and pathology or an abnormality of biomechanics will work in one area, will affect other joints. And this was a really interesting paper from David Beveland, he of the transverse ligament fame. And really, he was doing some gait analysis on patients, young patients, 10 years after their implant. And even the youngest hip replacements didn't get normal gait kinematics at 10 years. So actually, if you measure these patients, although they're happy, they're not entirely normal, most of them. And I think we can do better, and that will help their other joints as well. So the system that we have is a portable system with accelerometers and goniometers, and you can tie them to around the pelvis, the thighs, and the shins, and then you can compare left and right, so that this patient's normal hip is their right hip, which shown in blue, and you can see, for instance, with flexion of the hip, the deformity, the angulation is not so great, and the acceleration is not so great, and you can see the effect in the other planes. And there's a traffic light system compared with normal of how these patients are walking between before and after. So if again we think of what we're trying to do, we're trying to get the mechanics right. Of course, the center of rotation of where you put the cup is one of those as well. It's not just the femoral component, but it's also soft tissue preservation and balancing. And 20 years ago, we were talking about the knee being a soft tissue operation. I think the hip's a soft tissue operation. And there's a huge tendency at the moment to go to dual mobility as the way of getting out of dislocation. But actually, I think soft tissues are much more important, and leaving them intact as constraints to movement. If you think of, if you flex your hip up, normally your normal hip, it doesn't circumduct freely. So something stops it moving, and it's either impingement or it's soft tissue tension of something that we might cut. So I think the soft tissues are very important. And the Mako, the robotics, is really helping us with these things. So just going back to what happens if we don't get these things right, there is an impact, and you can measure it on gait. And this was a paper from Chicago, I think, where they did gait analysis subject to 50 people before a unilateral hip replacement. And then they looked at the contralateral knee, and there was significantly higher medial loads on the other side. And that persisted after THR. So patients with osteoarthritis of one hip are putting big stresses on the other knee. And if you don't get it right, then of course that can continue, and you can get pathology on the other side. They may preferentially require knee replacement on the other side. So I think there's a whole lot of things we don't know about how well we're getting these patients recreate in terms of their biomechanics and their gait, and that we should really concentrate on this. And the other one is objective measurements of activity. And now, of course, there's things you can wear on your wrist, and there are medical grade ones that you can look at level of activities, how much they do, when they're very active, what they're actually doing. And I think this will be something else that we need to concentrate on. So planning the best hip replacement really depends on precision of implant positioning, which the Mako can help, but also soft tissue preservation and balancing. And I've got a test for someone. I don't know whether you want to choose someone, Chris, to tell me which of these blobs is which of the insertion of the external rotators. So for instance, this one, would anyone like to guess what this tendon is, this insertion point here?
Josh Anderson, can you answer that for us? You on? Some of them may not. Yeah, he's on. There he goes.
No, this one here.
Yeah, that should be. No, it's not piriformis.
I'll stop you there. It is piriformis. Because when I learned to do the spare technique really because I went off and did 20 direct anteriors, and I took it very seriously. I went to multiple centers of people who did it really well. I must say the majority of people, it was like throwing a hand grenade in the wound, but there were some people who did it well. But what I came to realize and understood myself is I didn't really understand the anatomy of the external rotators. And I think most hip surgeons don't. So I wasn't trying to catch anyone out there. But if, we tend to cut things and ignore them. And actually, there's a surgeon in Belgium whose name I've just temporarily forgotten, who did his PhD looking at where these things are inserted. And it made me realize that you can preserve even more tendons. So, you see in the textbooks, the piriformis obturator internal, obturator externus, you assume that they're inserted in line on the inside of the greater trochanter, but they're not actually. So that's piriformis. That is obturator internus that you can see there. And obturator externus is almost always in the same place that you can see at the back there, and then gluteus medius sort of clothes over the other side. And I suspect most, even hip surgeons, don't fully appreciate when they're doing a direct anterior exactly which tendons they're releasing. And of course, minimus goes around and is clothed around the front here. And so it's important to preserve these things. And this was a really good paper from Japan, where they looked at a lot of specimens and found there was some quite slight difference in the footprint. So obturator internus tended to be in this area. Piriformis is further posterior and further proximal, as you can see here. Again, a bit of a difference. Externus, they found, was always in the same place. It pretty much always went into here. But the important thing to notice here is if you can imagine putting a slot in the femur for your component, and it's antiverted, then it will be going into this patch of bone here. And actually, there's nothing inserted in there. Well, there's externus, but I've accepted we're going to take one of these tendons because we've got to get into the hip joint. So we're going to take externus, but you don't need to interfere with obturator internus with most patients or piriformis. So this area here, you can go into leaving these tendons intact as long as you can do that. So if you look at the so-called muscle sparing approaches, there's the direct anterior, the spare, which is the one that I've described with some colleagues here, and the direct superior. If you look at the direct superior, these are the things that I think you divide: the superior capsule, piriformis, obturator internus, and with difficult cases, you have to divide other things. As I mentioned to direct anterior, almost always you take obturator internus and other external rotators. And in the difficult ones, you see people releasing absolutely everything till they pull the whole thing up. And some, honestly, it was like seeing a hand grenade go in the wound. And it made me realize that the direct anterior, although it could be done really nicely in some cases, couldn't be done reliably, preserving the soft tissues in all cases. And of the cases that I did, because we were developing some instruments for the EXTER, I had two patients who came to me with groin pain. And one of them came with 3 sheets of A4 had ruined her life with this groin pain. And I think you do see more groin pain, even if you repair the anterior capsule after a DAA. I may be talking to a load of DAA enthusiasts, so we'll have a discussion about it. But in my hands, there did seem to be an increased incidence of groin pain I had not seen before. And I realized that you could just take obturator externus and reliably leave all of the other tendons intact with slight modification in technique. So if you look at the interval, the femur and the glutei have been taken away, that for a routine posterior approach, you would divide everything to the right of that line. So piriformis, obturator internus, the gemelli, and obturator externus. Most of my colleagues and a lot of people in the UK now, I'm sure in the US, are doing piriformis sparing, and the piriformis is not such a strong tendon. And at the end of trying to preserve it, you quite often find it's quite patulous, and I suspect you avulse it from one end or the other. But the one that's got the real strength is obturator internus, and that is a very strong muscle. So is externus, but you've got to cut one of them. So that's the only one that you reliably take by this spare technique, preserving all the other ones. And we've written it up. You can read about it, Hip International. If you are interested, it's on View Medi. There's lots of different videos. So if you look at this, is a right hip. That's the sciatic nerve. I've got a retractor just under the glutei there. We've missed it. So you're going in the interval between the inferior gemellus and quadratus femoris. And bear with me. Okay. So I'll try and get this to work. So you get in the interval between the inferior gemellus and quadratus femoris, and then you'll need your assistant to abduct the leg a little bit so you get underneath it and just clear the capsular adhesions off. And then you can make the capsular cut in exactly the same place as you would normally make it. And then the thing that you need to do, and you have these bent homens that you can put underneath and the inferior gemellus. And then by pulling on that, you can see underneath and cut the capsule down on the femoral neck through the labrum and find that gap between the femoral head and the rim of the acetabulum. So this is always done under direct vision. So you just see it going through the labrum there. And then you put a stay suture in the back through the posterior capsule and through obturator externus, and take that as one stay suture. And then you flex and the hip comes out in the normal way. And then you have to flex the hip up. And so it's about 80 degrees flex, and you put it onto a Tremano table. So you need to flex it up and abduct it slightly. And then you can go around the rim of the acetabulum, and you basically work in this gap between the anterior retractor and the inferior retractor. And the socket exposure is the slightly more difficult thing, which is why Mako is so good, and I'll show you that. But then the femur is exactly the same as I've just shown you. The interesting thing being that because of the insertion of obturator internus, it actually pulls piriformis out of the way. So trying to get to the femur is absolutely no problem. And very occasionally you can just peel a little bit of piriformis or obturator internus off, but the rest of the technique is the same. So if you're using a Mako, you'll plan exactly where to do this. You put a screw into the trochanter on the side here. That's where you're going to put the femoral array. And then you have a checkpoint so that you can make sure that the femoral array doesn't move. And then you register the femur so that we'll get the femoral anteversion from this, as well as the offset and the leg length. And then so you just teach patients how to CT scan. You teach where the femur is, and you burst those bubbles so that the femur so the robot knows where the femur is in relation to its arm. Then cut the neck off. And then the exposure is, as I've shown you, it's slightly tighter. And because of the exposure, the pelvis tends to flex and twist a little bit. So that's why the Mako is so important, because you can very reliably put the acetabular component in the right place. So again, you show it the surface of the acetabulum, pop these balloons so that it knows exactly where the pelvis is. And then it reams, holding the center of rotation in the right place. And basically, you ream the green away until you get white. It won't let you go too far. There's an instrument just to be able to take the reamer out. And then the cup you put in, then you put the arm on it once it's inside. And you could actually take all the retractors out at this point once you're inside, because you don't need them, but you're underneath all the external rotators. You just check that the arm is correct. And then you've planned exactly the amount of inclination and version that you want. And it holds it in exactly that vector. And it gives you a readout of 3, 2, 1. And it's always within a degree or two. I mean, it's uncannily precise. So now you can take it off, put the plastic in, and then I always check the face of the cup to make sure that it is where I wanted it to be. So you just go on the face of the cup with a probe, and it's always within a degree or two. And then this again, always use a TPS, especially if you're doing a spare technique, because you can create that footprint into the trochanter then. And then you will have templated in 3D, so you know exactly the version that you want to put in, as well as the orientation of the implant. So it's an even more accurate way of the 2D way that I showed you. If you can't get it down again, it's always that lateral bit of cortex there. And then you put an array on the brooch, and it will give you the version as well. So now it's predicting offset leg length and version from the brooch. If you want to do some adaptation at that time, you can. Then you do a reduction. You can see the combined version as well as the anteversion, and you can then dial in as much or as little as you want. There you can see again the strong trabecular bone at the top end of the femur. This is using Palakos, so it's a little bit more viscous. But the obturator in terms is pulling piriformis out of the way. This is the same. I'll just show you the final result. The horse collar. And then you can just check the versions again, and leg length will give you a predicted leg length. And then you put the head on and do a final reduction. And you can really hone it. So this is what the software looks like. So this is what was planned. I planned 45 degrees and 18 degrees. I actually achieved 45 and 17. I mean, it's unbelievable how accurate it is. These are the combined version. Put in 19 degrees of stem version. The combined version was 36 degrees. and versus the pre-op, it was 3 millimeters longer, and the offset was 3 millimeters increased. So at the trial reduction, it wasn't quite right. So at this point, because with a cemented stem, you can put it wherever you want. You can change all of those figures to get them as you wanted to. And it gives you a picture of what it looks like at the end. And then uncannily, it always looks the same. So this really is what I've been doing for the last 4 years, spare in everyone. And the Mako just allows you to get the socket absolutely in the right place. And that certainly in my hand is the sort of state of the art of what I'm trying to achieve. So Chris, I'm not sure if you have any questions about it. If anyone is interested in it, there's 2 things. Well, first of all, we've got an Exeter book. The 2nd edition has just come out, which is available from exeterhipunit.co.uk. There's no conflict of interest because any profit goes to our research charity, and so you can order through that.
So if anybody wants to look at it, I have 2 copies. It's a work of art, honestly. The cover alone is just beautiful. You can lay it on your coffee table and just admire the polished stem behind the black or gray satin finish background. But I do have a couple of copies for anybody interested.
Oh, please don't go to Dr. Pelt's office to read, but please buy your own because it'll help our research. Yeah, and also, but if you are interested, I think it's worth going to see somebody who does it, or it's on View Medi as well. But the great thing is if you start doing the spare technique, everyone's doing it at my institution for hemiarthroplasty because you don't need acetabular exposure. And you cannot dislocate these without a bone hook with the posterior approach. So, it comes across, the obturator internus comes across like a band at the level of the center of rotation. So for hemis, you can do it. And the ones to start on are really large offset valgus necks, because then you can usually get the obturator internus out of the way very easily.
That's great. Right before you cut off, I was asking about the distal cement mantle between the plug and the tip of the centralizer or the stem. What if it's too small? How important is that with the taper slip? It could even potentially slip and penetrate through a undersized distal plug. Is that a problem if it's got the forces directed external through the taper as well as the hoop stress?
No, I don't think no, it's not a problem at all. I mean, most of the forces are transmitted proximally, and you only want it to subside about 1 millimeter, 1.2 millimeters. So actually, although the instrument puts it 1 centimeter distal to the stem tip, I usually put it down a bit less than that because you don't need it. And in fact, Wroblewski has had his own collarless polished tapered implant. Was it CPA? No, what was it called? C-stem. And he used to try and get a bone block and get the stem tip through the cement mantle so that it was actually in the distal canal. I think it's useful to have cement distal to the stem, but it subsides 1 millimeter, so that distance is not important.
Yeah, thank you. Well, we have only 3 minutes left before the residents have to run off to the theater. So any other questions that anybody has? Dr. Christie, as one of our fellows, Dr. Anderson, one of our attendings, you guys have any other questions while you're on? Connor? I guess residents, anybody, feel free. Try to interject.
Ready to get to work.
Throughout the time, so hopefully that was helpful. Well, once again, we can't thank you enough for the time. We really do want to extend the offer whenever it seems feasible to have you come out and visit us, and maybe even reciprocally coming out there. I might take up the offer. Truly learned so much today, and I think there's much more we can learn. There's simply no replacing the in-person teaching opportunities that exist, whether it's experiencing in the theater or in a cadaver lab. And what we learned today, though, from you about technique and implant design and some of the biomechanics has just been unbelievable, and I think will help us as a department, as our residents in their education. I learned myself and continue to learn from you guys every day. So thank you for the ongoing strong work that you've done and continue to do. And again, thank you so much for taking time out of your schedule to join us.
Oh, thank you very much. It was an honor for me to talk, and I'd love to come over, and you're very welcome to come and join us here. That'd be fantastic.
Absolutely. All right, all. Thank you. Have a great day in the OR, and send an email to me if you want me to forward anything to Professor Timperley or have any other future questions. Thanks, guys.
Okay. Thank you.
Cheers. Take care.